All right, so you have a meniscus tear, now what? So we really have a lot of fear tied up in when someone tells us that there's something wrong, that there's an issue. And we kind of, think of this, I always think of this little scene here in The Wizard of Oz where, lions and tigers and bears. So this is one of the things that we think about, when we hear anything's wrong with us really, and you're not sure what to think, but it generally causes some fear of what you might be recommended or what's next. All right. So what really is a meniscus tear? Okay. So this is a tissue here that essentially exists as a C-shaped cartilaginous structure that helps pad between the bones. And I want to show this in terms of the anatomical area. So I'm going to jump in here and show you what that looks like on our skeleton. And so right here, we're going to take a little side view. And we can see the meniscus popped in right here. And so there's the lateral meniscus, and here's the medial meniscus. And so as I zoom in, I want to isolate that for you so that you can kind of get an idea about what that is. So this moves pretty fast sometimes. So pay attention here, and you'll see that. And you can see this lateral side, you can see the posterior aspect, and you can see this cushioning right around in there. And that's what that looks like. And you can see how that pads between the femur bone, which is located here, as well as the tibia bone, which is located below. All right, so we're going to go back to that so you can see the highlighted version. But I think that really helps you kind of understand where that is and how that sits between essentially the cartilage surface above here that is on that surface of the femur bone, and then you've got the padding in between. So that should give you a really clear picture of what we're talking about. And both of these can be involved in meniscus tears. All right, so coming back over, we're going to jump to the next slide here. Now, what's the definition of a meniscus? I put this up just because I wanted people to understand the medical kind of definition of what a meniscus is. But the key factor here is how you transfer the weight and the absorption of shock during dynamic movements of the knee. And that's key during these dynamic movements. And so really protects the cartilage in the joint. So that's a key factor. And so when you have a tear in it, there's some concern that you may ultimately develop some challenges, in the bone, in the cartilage surface. So, all right. So now let's talk about, how common meniscus tears are, So is this something that is not uncommonly or not a common feature? Well, actually, it's ridiculously common to have this. So this is a really good study. It was done, published in the New England Journal of Medicine, and basically looked at what number of people have meniscus tears. And I want to make one distinction because this really gives you an underestimate of how many people have meniscus tears because they only looked at the right knee. So the percentage of people, when they looked at these patients, they said, hey, we're going to just look at right knees, and kind of makes it easier to do the study and just look at one leg and they had to perform many, many MRIs to actually find these people. So you can potentially double the frequency here. So going from 1 in 5 in females aged 50 to 59, which was on the low end of the prevalence, to over half, 56% of men among the age of 70 to 90 have a meniscus tear. And that was just in the right leg. So imagine if you said, hey, we're going to scan your right and your left leg. This number is going to shoot from 30% potentially up to 40%. And so that could be an almost doubling of this number. And then you look at this, that's essentially going to be almost everybody, almost every man aged 70 to 90 is going to have a meniscus tear in either the right or the left leg. That gives you some idea of the frequency. So I tell patients, look, if you live long enough, you're going to have a meniscus tear, and you very often don't even know it. And so we'll talk about that here more in a moment. So, all right. So does a meniscus tear cause pain? Right? That's a big question that people want to know. Well, this study found that 61% of the subjects who had a tear, okay, so that's almost 2/3 of the patients, didn't have any pain, achy feelings, or stiffness during the entire previous month. So there's your answer, is that actually it's more common to have a meniscus tear that does not hurt. And that's pretty interesting. And they didn't say, hey, pain from the meniscus tear versus pain from osteoarthritis or pain from something else. They said pain at all. So very common to see meniscus tears, actually more common to see a meniscus tear having no pain than actually having pain. So that should tell you something. All right. So then, so moving on here to, what treatments are commonly offered? Physical therapy, a blind steroid injection, arthroscopic surgery, meniscus resection. And typically the arthroscopic surgery is going to be performed at this, in order to see the meniscus, and then they'll go in and do what they call clean it up. Okay. That almost always results in a shaving of the meniscus. They're going to actually cut a portion of the meniscus away. Now, remember, what do we know now about the function of the meniscus? It's a padding between your cartilage to help you maintain the bone. So ultimately, this all leads down the road to a knee replacement. And that's where they're going to come in, and they're basically going to cut that joint surface out and replace it with a metal alloy, and you cease to have a normal joint. So, all right. So basically, when we look at this, traditional orthopedics really has one mainstay. It's all leading towards joint resection, and ultimately, whether you realize it or not, if you're having steroid injections, especially repetitive steroid injections, and then ultimately you're going to have a knee scope, which many of my patients believe, either one, they think that actually decreases the likelihood of surgery, which it does not. You'll see that here in just a moment. But number two, they think, oh, well, I'm getting a repair of my meniscus. I actually have to re-educate people almost weekly that when you have an arthroscopic surgery, and if you're, be above the age of 35, 40 years old, they're really not a good indication to do a repair of the meniscus. If it's a degenerative process and it's not something that's very acute, and you're not a high level athlete, the odds are you're not getting any repair there. They're actually cutting a portion of it out. And I actually have to explain that to patients. And sometimes I get the surgical note and I explain to them, look, they actually shaved your meniscus out as opposed to repair it. And I think that's important, because you certainly can get the impression from the words that are used when somebody says they're going to clean it up for you. You think, oh, well, you're going to make it better. No, actually, they take a portion of it out. And we're still, right, we kind of go into this, the steroid injections and kind of going back through that sequence of events, and as little as 2 years, you basically can get into a situation where you're losing cartilage. So there was a study that was performed that looked at this and said, hey, if we give a patient a steroid injection for every 3 months for 2 years, they could actually measure the decrease in cartilage. So we know that high dose steroids in the doses typically used in an orthopedic office are toxic to the cells that maintain the cartilage. And so while you feel like, hey, I'm going down a non-surgical pathway, you're actually making it more likely that ultimately you get surgery. If you're having these serial injections, year after year, you really have to think long and hard about that. Okay. You might get some benefit in the short run, but you're definitely going to pay for it in the long run. All right. So then we talk about knee arthroscopy. What does the research show? So there are multiple studies out for more than 20 years now that show no efficacy for knee scope in patients with osteoarthritis. And so doing a debridement, which is where they essentially translate that into lay terms as cleaning the joint up, these things have been studied. And even here, you'll see this is an actual quote from one of the medical research studies that says, look, we're still studying these treatments, perhaps searching for a different outcome. In other words, the outcome has been clear. No efficacy is shown. They've actually done what they call sham surgeries, where they simply give the patients a surgical scar, but they don't do the procedure. And then they have patients that actually got the surgery, and they can't tell the patients apart at the end of the study. There appears to be virtually no difference between the outcome. So that's pretty shocking. All right. So again, this is medical research out there that shows no benefit for knee arthroscopy, more studies. And then here we've got, surgery for adults with meniscus tears. And this is pretty rough. I feel like I'm beating up my surgery colleagues tonight, but the data is the data, and this all comes from their area. So we're looking at this from surgeons' criteria, right, used for deciding that surgery is indicated in a sample of patients with a degenerative condition, a meniscus tear, resulted in a prediction that is as accurate as a coin toss. So I want you to think about that. The reason they did the study is because surgeons were saying, yeah, we understand that, some patients don't get benefit, but I'm very good at choosing patients that, and I know, as I'm saying from the viewpoint of these surgeons, right? And down here, I want you to look at this: 194 orthopedic surgeons who made almost 4,000 predictions. Okay, and one of the most esteemed sports medicine journals looked at this just in 2020. So this is very recent data, and they said, "Hey, we looked at these 20 patients that had procedures, and we want you guys to predict who had benefit and who didn't." And what they found is that the surgeons could have flipped a coin, regardless of how experienced they were. None of them were better than a coin toss. And so mere chance was as good as the surgeon's judgment. So that tells you something. Okay. So and essentially that says that they cannot pick who will benefit and who will not. Okay. All right. So we're going to get into some questions here, and we're going to talk about what you guys are finding interesting so far. And I always like to try to weave in some questions here for the audience to, give you some idea about what's going on in your specific situations. And so, all right. So all right. So one of the questions, and we get this one almost every time we do a webinar, is can you regrow cartilage? Okay. So, when we get that question, I want to say, I think you're focusing on the wrong thing, because regrowing fresh cartilage is a challenge. That is not something that is been medically easy or feasible. What we want to do is preserve the cartilage that you have. That's why we hone in on so much on these high dose steroid treatments, and really looking at this from the standpoint of, how can we keep the cartilage you have and not have it more damaged? And this gets into this whole concept of bone on bone. I hear that term almost every day. Sometimes we have a game in the office where we count how many times we hear the word bone on bone. And as it turns out, I have never seen a patient come into my office, out of the thousands of patients I've seen, I've never seen a patient have no cartilage in their knee joint. Never, no matter how bad it's been. I always find some cartilage. Now, some patients, to be fair, have pretty severe damage, right? And they're not candidates for, in our opinion, an orthobiologic procedure or regenerative procedure. But the idea that you're going to take a patient with very severe loss of cartilage and completely regrow that cartilage, that's not a realistic expectation. And really no one can predict that. So I say, look, we're trying to maintain what you have and make it function better, and better enable your body to restore the cartilage into a higher functional level. And that decreases pain, inflammation, and we can strengthen and improve the overall stability of that joint so that it can then function very well, despite having a little bit of damage there. And so, as opposed to the traditional approach of just going in and cutting the joint out. All right. So how long is the recovery from the procedure compared to surgery? Now that varies quite a bit, and I'll go with two main flavors. And I'll tell you, as I tell patients, each procedure that we do is a very specific and custom treatment. We tailor that to you because we do an extensive workup. So one of the things I'll point out here is that I find most commonly patients have had only an X-ray to determine whether or not they're going to have a knee surgery. whether that be arthroscopy with the meniscus, procedure, or knee replacement. The challenge there is that, you can't see the cartilage with an X-ray. You can only infer the cartilage. And so why is that? Well, we'll kind of hit this topic maybe a little later, but the cartilage is actually mostly made of water. And so you can't really see it. You can only infer that spacing on X-ray. So it depends on how severe the damage. And again, you can't really know how severe the damage is without doing a full workup, using things like musculoskeletal ultrasound, using things like MRI to help you really understand what's happening inside that joint. And that determines the treatment that's recommended. So if I can't ultimately get a more specific diagnosis and find out the condition of your bone, which supports the cartilage, it's difficult for me to know which one to pick. But again, we do that on every patient. So when we do that, we actually look at it and say, look, if you're on the low level of, you've got mild, sometimes even moderate osteoarthritis with no obvious bone damage, we're going to be able to stay in the platelet-rich plasma or the PRP camp of treatment, where you're going to recover much faster because it's not as invasive and it's just inside the joint. Now, on the other, and we're talking, days to a week or so in terms of post-procedure, very fast recovery. We do it with athletes, and we have them sometimes back on the field in a week or less. So I've actually done treatments in patients, literally they're back out playing their sport in a matter of days. Now, on the other hand, if you've got more severe damage, then we're going to go in and use bone marrow. And sometimes we have to do what's called an intraosseous injection to try to stabilize that bone and really make it support the cartilage. Doing that takes a little longer for recovery. So that's typically measured in a week or two. Now compare that with what we typically see with a knee replacement, which is a really invasive procedure. Most people that have a knee replacement for the first time, that is the most invasive thing they've ever had done. And I've had patients that have had heart surgeries tell me that it was more difficult to recover from a knee replacement than a heart surgery. Imagine a bypass surgery. You think that's pretty invasive, but they actually had more difficulty with their knee replacement. And there's a lot of reasons for that because, it's a major joint and bone structure that they're cutting out there. So comparatively, our recovery times are measured in days to weeks, depending on the type of treatment that you have. And the great thing is that we typically have continued improvement over a period of months, which is typically 3 months, 6 months, 9 months, many times over a year. And our data shows that. In our patient registry, where we're currently tracking about 150,000 patients, we're seeing continually in almost every area that we track, patients do better over time. And that's pretty exciting. So, all right, so we're going to jump into the next section here and talk about, other things about meniscus surgery, okay? So in patients with osteoarthritis, and again, that's many of the patients that have meniscus injuries, merely taking out the meniscus causes a 300% increase in the risk for future knee replacement. So let me say that again, because I think it's worth repeating. So now imagine your goal is to not have a knee replacement, but you're going to be exposed now to a procedure that causes you to be 300% more likely to have a knee replacement. Well, if your goal is to not have a knee replacement, this is the last thing that you want to do, because there's not many other things that predict that you're going to have a knee replacement besides this. So this is stunning, right? But this is the traditional approach because they really don't have these other techniques. They haven't been able to incorporate these in ways that allow you to have the benefit of an orthobiologic procedure that doesn't include surgery. So, all right. So then other things that we look at here is, the evidence supports non-surgical approaches. This is yet another study. In all 6 reviews of randomized controlled trials, they weren't able to show a clinically important benefit over conservative treatment. When you look at arthroscopic procedures for patients with meniscal injuries and osteoarthritis, The evidence is clear. And again, this isn't me. This is the orthopedic literature, and this is level 1 evidence, which is the best medical evidence that we have. This article was published just now in 2021 in one of the most esteemed international journals out there, the British Medical Journal. So, you think about that, and the real question, and orthopedic surgeons around the world internationally are asking this question: why are we continuing to do these arthroscopic procedures for patients? And in the United States, we're doing about 700,000 of these procedures on an annual basis, and it doesn't seem to be slowing down, consistent with this literature that's been out now for years. So really important to think about. So what happens when you take a blind steroid injection, high dose and toxic levels, and then you mix that with a knee arthroscopy and basically destabilization and cutting down on the padding between the bones? What happens? Ultimately, you end up with a knee replacement, the most invasive thing that you can do to your knee. And that's just the traditional approach. And so this is what we call, you're on the road to surgery. If these treatments and these recommendations sound familiar to you, you're on the road to surgery, whether you realize it or not. And it doesn't matter if you come and say, look, I don't want knee surgery. Well, this pathway actually makes it more likely that you're going to get there, whether you want to or not. All right. And this is why we encourage you to really think about what else is out there. One other thing I'd like to point out about knee replacements is that, we talk about studies, and I hear that a lot, from my, again, orthopedic surgery colleagues. They say, well, but, there's not any data behind, orthobiologics or regenerative care. That's absolutely not true. Now, granted, I can't make you read the data that's out there. I can't make you come to the conferences where we discuss these things in great detail. And, and you're not very often going to find those types of topics discussed in a surgery-based conference because it's not their forte, And by the way, we don't do a lot of, surgery lectures at our conferences because we're trying to avoid surgery. So I tell people, look, who do you trust to do a non-surgical procedure? Who's better at a non-surgical procedure? A surgeon or a non-surgeon who's spent their entire career perfecting their techniques to approach this? So that's, I think that one is obvious. But one of the things that's important, and I always bring this up when they ask about data, we have literally hundreds, thousands of research papers on our field for non-surgical treatments and regenerative. But this is data that was published in 2021, July of 2021. And this is a quote: "We found one randomized control trial published in 2015, which compared total knee replacement, to non-surgical treatment, including only exercise, education, dietary advice, use of insoles, and analgesics." And I want to point out those analgesics were not prescription analgesics. Those were over the counter. And so now imagine this was head to head. What's fascinating is that just using exercise, education, dietary advice, they were able to receive approximately 50% of the benefit that they got with surgery. But what they did find is that the serious adverse events for the patients in the surgical group were dramatically increased over these other patients. And these weren't patients that they really had really advanced disease. So if you bring in patients that are in that mild or even moderate levels, and in many cases even moderately severe, and you say, hey, we're going to now put exercise education, dietary advice, and all these other things that are low risk, plus an extremely low risk orthobiologic regenerative procedure, and compare that to knee replacement, nobody wants to do that study. So you think about it from that standpoint, that is potentially going to harm the industry of orthopedic surgery. And there's a lot of people that have a lot to lose if that study came out and showed, even if we're able to get a 75% benefit in these average patients. And we really think it comes down to patient selection, because you got to know when people are candidates or not candidates, and that's where Rethink stands alone in understanding that, right? How to determine who would benefit. We don't just do this procedure for everyone. You have to meet certain criteria. But comparing those head to head, may give you, some pretty interesting results. And when you compare that to, and just I'll throw out one statistic, the 90-day mortality rate, which means the likelihood or your risk of dying by merely having a knee replacement, is 1 in 400 90 days after a knee replacement. To give you some context, dying from a scuba diving accident is approximately been rated at 1 in a million. Dying in a hang gliding accident, if you are a hang glider, has been rated at 1 in 2,000. So having a knee replacement puts you at more risk of dying than if you were hang gliding. Just to put that in perspective, and you typically will never hear people kind of put it in those types of terms. All right, so basically, the road to surgery is paved with good intentions. I don't think that there's a surgeon in the world that has any intent for harm, but when you're a surgeon, you do what you do, and we have a saying, when you're a hammer, right, the world looks like it's full of nails, and that's what you do. And so they simply do not have the background, the skill set required for these advanced regenerative surgery-free approaches. And we really encourage you to explore your options before you just kind of accept this traditional pathway, because as we've shown with the orthopedic literature here this evening, it's got some challenges. All right, so Rethink Surgery, we want you guys to have more options, not less. All right, and then we get into why Orthobiogen, and these are just a few of the key pointers about Oklahoma's exclusive provider of Regenix treatments, board-certified subspecialist physicians, including myself, extensive interventional orthopedic experience in both spine as well as peripheral joint. So we're able to understand how those interplay with one another. So how does your knee affect your back and your hip affect your knee and those things? We deal with that on a routine basis. And we have the only orthobiologic tissue lab of its type in the state of Oklahoma. It's the most advanced facility. We do the most advanced tissue preparation, for minimally invasive surgical alternatives. So, all right. So, all right. So we're going to go to round 2 of questions here. And all right. So what supplements do we recommend to prepare for the procedure? That's a great question. We at Regenix are fortunate. We have a number of supplements that have actually been formulated specifically for our patients in our network. And so we use natural anti-inflammatories, curcumin, turmeric, those types of things to help patients, as well as we have something called a stem cell support formula that has some ingredients. Among some of the ingredients include chondroitin and some of the other things that have shown some value for patients that have osteoarthritis. And then we also here at our clinic, and I think this is unique to us, we actually have Dr. Castel Santana, who's a functional medicine doctor. So I want to give him a shout out there and let you know that we have one of the most skilled, most knowledgeable functional medicine doctors in Oklahoma. He treats patients from around the country. People seek him out and literally fly in to meet and talk with him, and he manages patients all over. And so we have a great advantage, and he uses techniques like peptides, nutrition, gut health to make sure that we're optimizing our patients. And I do occasionally see patients. I just saw a patient within the last couple of weeks that I said, look, you're not ready for an orthobiologic procedure because you've got a lot of metabolic challenges. So I want you to be in a sustained program for at least 6 months to get right with your health, with your diet, with all these aspects of your dietary anti-inflammatory things that you can do. And Dr. Santana is kind of my go-to on that, and he's got extensive background in those areas. And by and large, if I see a patient come back and they've been working with those types of specialists, and specifically Dr. Santana, we're going to have better outcomes because you're going to see better bone marrow counts when I have to do bone marrow aspiration and treat inside the joint for that. So you're just going to have a better quality, and you're going to be ready to recover to a much better degree. So highly recommend that. So we often recommend pairing that type of an approach with what we do. So, all right. So how long before we see results? So that again varies based on your the level of disease that you start with. So again, everyone's a little unique, right? And so if you've got early onset arthritis and maybe some more soft tissue damage, a little laxity in that joint that you're suffering, that's going to be very different than someone that comes in with a grade 3 or even a grade 3, maybe a little grade 4 deterioration, out of 4 grades, that 4 being the highest. We kind of look at that and say, okay, your outcome is going to take a little more time, but we almost always see improvements in pain, and most often see some with a decrease in pain and inflammation. We get you in your therapy program in conjunction. We're able to see results in function as well in a matter of weeks. And so it's common for patients to continue to improve through a period of 3 months, 6 months, as I mentioned before, even out to over a year. And so compared to surgery, you're still recovering from surgery, the wounds of surgery within that 3 to 6 month period typically. And a lot of patients, if you've ever had a surgery, kind of know what I'm talking about. Your idea of recovery as a patient is very different than the surgeon. The surgeon is going to tell you they don't need to see you anymore far before you're going to feel like, hey, you're fully recovered, because that's just how it works. Okay. All right. And how long can I expect the results to last? Which is a follow-up question, to the last one is, we typically see patients benefit from our procedure for years. And when you see the level and the specificity of our diagnosis and our understanding of what it is we're working with and how we do, our treatments, it is very common for us to see patients benefit for years. And so that's a common question. A lot of facilities out there, they want you to come in and, hey, come in and get an injection every, month or two. That's just not feasible for the busy professionals, the athletes that we see. They've got things to do, and not to mention the cost. And so, when you're doing that, I question, the procedure, and typically we're seeing patients benefit for many months, if not years out. And so we'll see patients. I've had patients come back that are in excess of 10 years out from their last Regenix procedure. And they may have had it in a different city, in a different state, from one of my colleagues, and then come in and see us and say, hey, I've done really great for the last 8 years, Dr. Booth. I'm thinking of one particular patient. And they say, wow, I've done great, but I'm starting to notice this issue, and I'd like to, see if I can kind of get things back on track. Absolutely, come on in, and then we, get everything situated and get them back up to speed, and they're off living life again. So, so I personally have met many patients 8 years, 10 years, 12 years out, and that's the other benefit of Regenix is we have. Historically, we're in our 18th year as a physician specialist network around the United States, providing these types of therapies and treatments for patients. So, nobody has more data and has been doing this longer as a network of subspecialist physicians. And that takes a tremendous amount of training, skill, and we're constantly learning and educating ourselves about what is the latest and what is the science tell us, right? And so, and this is probably a good segue into another question. I have patients ask me, they say, well, Dr. Booth, I really am excited about the potential that we're talking about, but I asked my surgeon about regenerative procedures, and they told me that they don't believe in it. And so, what do you say to that? I said, well, it's important for you to understand that regenerative medicine, orthobiologic treatments, it's not a religion. It's not a question of whether you believe in it, right? There is a lot of data to back this up. And we have 500,000 patients that have undergone Regenix procedures since its inception, 500,000 procedures. So imagine that, so this is not a belief system. This is a science-backed and really patients are tracked for outcomes, for safety. And we have an unparalleled patient registry, and we follow protocols around the world at all the Regenix clinics. And these things are tested. We're constantly checking and confirming that we're using the appropriate techniques and training. And so it doesn't matter whether you go overseas to Europe and have a Regenix procedure, you're going to see the same types of protocols used around the world. And that is all based on the science behind what we do. So I want to stress that it's not a belief system. And if your doctor, and I don't care whether it's a surgeon or your primary care doctor, justifies his decision-making based on his belief system, then frankly, I would recommend you get a second opinion, because maybe that doctor is not familiar with the prerequisites it takes to be a scientist and make objective decisions, as this is not based on what you think or feel. This is based on actual data, which may explain some of the problems that we have, as you saw earlier, with the data that we're seeing about, because I could easily say, hey, I don't believe in doing an arthroscopy with a meniscus resection, right? Well, it's not a belief. I'm actually going to the data and saying, no, the data says that we should not be doing this and that it's actually bad for patients. It may not help at all. And the data shows it's more likely for you to ultimately end up with a knee replacement. That's not a belief system. That's what the data shows us again and again. And these studies have been looked at. So, so it's one of those things where I just want to point that out. So I always like to take an opportunity to explain that. So you should probably, think twice if someone tells you, hey, I don't believe in something. Hey, it's not a belief system. It's not a religion. Okay. All right. So next question. All right, so we're winding down. And I wanted to apologize again. We had a little bit of the mic difficulty in the beginning. So, but if you feel like you missed anything, or for those of you that needed to watch that over again, this is all going to be recorded and rebroadcast and made available to you in its entire form. And then we'll get that out and set up for you. So the next step is, what do you do? How do you determine if you're going to be a candidate for an orthobiologic procedure with Orthobiogen here in Oklahoma City? And I'll tell you, this isn't a bait and switch. If you come to our office, you will see me personally, and I will be the one doing your exam. There's really no substitute for someone that has the background training and the skill sets to allow us to truly be able to understand what is going on with you. So ultimately, before any procedure that we ever perform, you will personally see myself at our clinic, and we take a great deal of time. And I make this guarantee to every patient: you'll know much more about your disease state, your pathology, and what is going on with you. And we'll make sure you understand what's happening. Whether or not you're a candidate is a second question, right? And I'll tell you, just like I would tell my own family member, look, if I don't think I can help you, I'm not going to offer this as a therapy, because that just, for me, we have plenty of patients that are candidates, and I wouldn't want to steer you incorrectly and give you a false hope. But if you're going to a clinic and they have an answer for everything that you have, and there's going to be a miracle cure, that should send off some red flags for you and alarm bells. And we just simply don't do that. And I believe in a principle of, let's under promise and over deliver. And that's how I've lived my entire clinical career, because I think it's important to be upfront with patients. And so you'll always get that straight talking, straight shooter, and give you the data. So, all right. So with that, we got the phone number there. And so give us a call, and look forward to it. And stay tuned for our next session. We do these on a monthly basis, and we cover different topics. So next month, I believe we're doing, is it spine or shoulder? Probably a little bit of both. Okay. So we're going to be talking about shoulder here, rotator cuff, which is another great area for orthobiologic treatment. Okay. Well, thank you, and good night.